Well, with us today, Dr. John Hovannisian from Harvard Eye Associates, and he hasn't been on with us for a while, and we were talking right beforehand. There are so many great doctors over there at Harvard Eye that he was out of the rotation for a little while as we met with a lot of the others, and they're all great.
I'm glad to be back on the team and coming in and seeing you.
I know, we're putting you back in the lineup again.
That's right.
But it's been a pleasure having everyone on from there. We learned so many different things.
We have a lot of great docs who really are passionate about what they do. They love helping patients and talking about the work they do.
Yeah, and so you guys are expanding. You got the surgery center and all kinds of things.
We have a wonderful team, and we have the nicest patients in the world who send all their friends and family, and that has caused us a good problem to have. How do we take care of all these folks in the same way that, with expertise and with attention to detail that they deserve? And so it's been wonderful to grow and have new smart doctors who join our
really
group,
great
bring new skill sets. So it's all great.
Well, today we're going to talk about glaucoma, and as we get into it, about the different types of treatments, particularly using stents.
Yeah. So, glaucoma is a disease that's really quite common. Mm-hmm. As many as 1 in 4 patients who come through to us for cataract surgery have a problem with the pressure in their eye being too high or having damage in the past to their optic nerve from this disease, which usually occurs with high pressure in the eye. The eye is a sphere, and it's got a fluid pressure inside. And one of the common areas where the fluid backs up or the pressure becomes high is in the picture we'll show you here, which shows the flow of fluid through the front of the eye. So what we see here is a cutaway of the eye that's got the angle that fluid normally flows into, and into that channel. If fluid can't get there because it's partially blocked or because there's just not enough flow through that area, the pressure in the eye will back up and become high. And that will cause damage way in the back of the eye to the optic nerve. So one example in the next picture is what happens when that pressure, when the fluid actually can't escape. There's a condition called narrow angle glaucoma.
Okay. This is... And I don't mean to interrupt you, but one of the things I want to ask very quickly before I forget is when the pressure kind of builds up, do people feel something? Like they have, I don't know, like a headache or sometimes you can feel, if your eyes are tight or something, you feel that pressure.
Yeah, that's a great question. Okay. In most glaucoma, people don't feel anything.
Okay.
The eyes feel normal, they look normal, and there's no way to tell the pressure is high.
Okay.
It's like high blood pressure. You can feel perfectly normal and have a very high blood pressure. And so it really has to be measured in a proper way.
Okay.
In some cases, like narrow angle glaucoma, which is shown in this picture, patients may actually feel something. This is a case where the fluid backs up in the eye and the pressure becomes very high over a short period of time. Mm-hmm. But this is a small number of patients who develop this. The more typical case is sort of the run-of-the-mill open-angle glaucoma, where just not enough fluid, the pressure in the eye is high because not enough fluid is escaping through the normal channels. So, so what do we do about it? Nowadays, when we're going in to do surgery for cataract, which has become the most common surgical procedure in the U.S., we can also do separate steps to treat glaucoma.
Okay.
And one of the more common ones, a local invention and a very effective, now FDA-approved treatment, is to use a stent. Most of us have heard of stents for the heart, where stents help to take blocked blood vessels and allow flow. Well, a stent in the eye is the smallest implant placed in the human body. There's a picture here on the screen of it, and it's the smallest. It's about 1 millimeter in the longest length of that device. And it's placed in the eye on the end of a long insertion device that eventually goes away, and it's placed in the edges of the angle where fluid normally leaves the eye. So after it's in there, you can't see it when you look at someone's eye. We have to use special instruments that give us a view like we see on the screen to to see what is actually to see that it's even there.
So are you actually draining fluid out of there? And if that is the case, where is that fluid going? Is it looking like tears or something, or?
Well, it's a great question. The normal flow of fluid in our eyes is that the fluid leaves through the angle between the iris and the cornea. This is inside the eye, and then flows eventually through a series of channels into the veins that go back into our bloodstream.
Oh,
so
really?
it doesn't become arterial.
Interesting.
There's no communication from the inside of the eye to the outside, as in the fluid becoming tears. So it goes into our bloodstream. And this allows it a bypass route, a stent,
Right.
that facilitates that flow more easily, and that therefore lowers the pressure inside the eye to a level where less damage or no damage can occur.
Okay, these are about a millimeter?
Yeah, about a millimeter in length.
Okay.
And they don't cause pain. They take just about an extra minute or two to place in the eye.
Wow.
While we're doing cataract surgery. So yeah, it's not a big procedure. It doesn't add a lot of time or risk or healing time with surgery. So we use them for appropriate patients who have this combination of conditions.
That's amazing that it only takes a minute. Now, once a stent is in, does the patient ever feel it? Does it feel like there's something? You know how you get a little something in your eye?
Right.
That's what I'm imagining, but I'm sure that's not the case.
Well, looking at it, you would think a device in my eye must hurt, and in fact, it doesn't, because the inside of the eye, there are not nerve endings like there are on the outside. The outside of the eye is about as exquisitely sensitive as any part of the body, but the inside of the eye in this area won't feel it.
Okay, now the next picture, is this a different procedure we're going to see here?
Yeah, I wanted to just give you an example of some different procedures. We also use this approach. This is called a trabectome. This is what it does is it takes that outflow channel and it unroofs the area. There's a membrane that the fluid flows through. And in the case of the stent, we just make a hole in that membrane and allow fluid to pass through the stent. In this procedure, we actually remove much of the membrane itself.
Okay.
And we do that by more or less vaporizing it inside the eye. And this strategy seems to work very well too. This approach also is FDA approved. And it's a little larger procedure, perhaps a little more traumatic to the eye. It may achieve a little greater lowering of pressure in the eye than the one I just mentioned. It's effective though, and we use it for select patients.
Okay, would that be the type of patients you mentioned that some conditions, this glaucoma, this blockage and pressure can form a little bit more quickly? Is that when you would possibly look at this procedure?
That's a great question. Typically for that type of glaucoma where it develops quickly, where you have higher pressures, we do treat surgically, but we use a laser. In that case, we create an opening in the iris to create another type of bypass.
Okay.
So either way, we're basically creating a bypass of one sort or another. So where we bypass and how we bypass is determined by what where the blockage is really. Just like in the heart, we can bypass this vessel versus that vessel. Here, it's different parts of the eye.
Here we have this as another type?
This is yet another type, a TRAB 360. This is the last type I'll show you. Here what we do is to unroof that membrane, to open that membrane I mentioned. We insert a catheter that goes all the way around this channel in the eye, underneath the membrane, and then we simply remove the catheter, and that unroofs the membrane as it comes out. It's not painful.
Wow.
It doesn't cause a lot of trauma or inflammation, and most eyes heal very quickly, and it works. It gives substantial pressure lowering. I wanted to show you these largely, not so much because the importance is not the difference between one and the next, so much as to understand that we have a variety of ways to treat glaucoma when we're doing cataract. We've surgery. We've had a lot of discussion about fancy new lens implants that we can use when we do cataract surgery. But here is something where we can really treat two diseases at one time. And it's very gratifying for our patients who in many cases have been on eye drops for years and years and years. And they're irritating and they're expensive, and we have to remember, but now we've got a way to reduce or even eliminate that need for drops without adding much time to surgery.
As far as glaucoma goes, how is the treatment differing today than, say, it was 20, 25 years ago? At one time, didn't glaucoma kind of mean that maybe you were going to lose your eyesight slowly?
In the old days. So great point. We detect it a whole lot earlier, and we can track it a whole lot better with newer technology. We've got a whole lot better eye drop medications, but still eye drops are kind of old-fashioned, and they take active participation to take those medicines. Yeah. We're moving more toward these very gentle surgical procedures that lower pressure effectively and permanently in many cases, so people need fewer drops, and that's exciting.
As far as glaucoma goes, is there a prevention for it? Is it associated with high blood pressure or any other type of condition, diabetes or something?
Those are common questions and great questions. It is a little more common among diabetics, but we don't think it's caused directly by diabetes, not in a way we understand. And we don't see there being, it doesn't relate to blood pressure. So your blood, one can be higher, the other, it doesn't matter.
Okay.
They're really quite separate. And there doesn't seem to be anything we can do to prevent it at this point. We're always learning more about how do we improve treatments.
All right. Well, it's great to see that all these different procedures there. And what's amazing is how quickly it can be done, and it can be done quite often in conjunction with the cataracts.
Yes, it can,
it's incredible.
This procedure just keeps getting better and better every year. The procedures we have, and giving our patients longer and longer life, quality of life, and good eyesight. So we don't ever want our eyes to be our limiting factor as we get older. We want them to keep serving us until the rest of our bodies is no longer functional. Exactly.
Thank you for the information, Dr. John Hovannisian, Harvard Eye Associates. And it's great. It's as I was saying, when you have your other doctors on and colleagues on, and they talk about these new advances and all kinds of different procedures, it's absolutely amazing.
Yeah, we're very lucky to be able to see and participate in these great advances in science.
And as you've said, Orange County, this is sort of the Silicon Valley of eye care, isn't it?
This really is. We're in the place where it's all developed, and being the largest private eye care practice in Orange County, we have a lot of interest from the companies in helping them to develop these technologies. So we tend to get, and we're very choosy. We don't just use everything that comes along, because our patients are always our first priority. We want them to have access, though, to the best of the available technology, even if it's not available to the rest of the world. So while we're choosy, we also are future-minded.
All right, great. Good to see you again.
Good to see you.
Thank you very much for stopping by.
Always a pleasure.
We'll be back in just a moment.